Hi and welcome. So today we're going to be looking at uterine fibroids, also known as leiomyoma. We're going to be focusing on the pathophysiology, the symptoms and treatments. We'll be looking at the various pathways in which leiomyoma affect the body and what really causes it. So in the next slide, we're going to be knowing what uterine fibroids are and how they affect the body. Before we proceed, like, comment, share and subscribe for more videos. So uterine fibroids, also known as leiomyomas, are benign smooth muscle tumors of the uterus driven by hormones and genetic mutations. Their formation involves various factors of which we'll be discussing in the next slide. So first is genetic factors. Up to 70% have mutations, especially in the MED12 gene. There's familial tendency, that's family history, which increases the risk. So in all uterine fibroids, there is a 70% case of gene mutations, especially in the MED12 gene, and a previous history, that's family history, which increases the risk. Next is hormonal influence. Fibroids are estrogen and progesterone dependent, so their activity is solely based on the body's production and activity of estrogen and progesterone. So, what estrogen does is that it increases growth by stimulating smooth muscle proliferation of the uterus. So, it causes the enlargement during productive years, that's the reproductive years. There's shrinkage after menopause and rapid growth in pregnancy. So progesterone on the other hand promotes extracellular matrix deposition. This makes the fibroid bulky and thin. So next is growth mechanism. Fibroids consist of smooth muscle bundles, dense extracellular matrix, which composes of collagen and fibronectin. Growth occurs via hyperplasia, which is increase in the number of cells, or hypertrophy, which is increase in the size of cells. Next is the subtypes and locations. Fibroids differ by location and therefore symptoms. So fibroids present with different symptoms based on where they are located. So first we have submucosal fibroids. These fibroids are found beneath the endometrium of the uterus. They cause bleeding and infertility. We have intramural fibroids, which are within the myometrium, that's the smooth muscle layer of the uterus. This one causes heavy bleeding during menses and pain. We have subserosal fibroids, which are beneath the serosal layer of the uterus. These ones present with pressure symptoms such as constipation. We have pedunculated fibroids, which are attached by a stalk to the uterus. Here they cause torsion risk. So we'll be looking at the symptoms and clinical features of fibroids. The symptoms depend on size, the number and location of these fibroids. So first symptom on our list is abnormal uterine bleeding. So heavy menstrual bleeding, also known as menorrhagia, occur in fibroids. Prolonged periods, intramenstrual bleeding, which is less common, most prominent in submucosal and intramural fibroids. So next is pressure symptoms. Large fibroids compress pelvic organs. So when the fibroid is very large, it compresses other structures in the pelvic cavity. So this causes urinary frequency or retention, constipation, pelvic pressure slash heaviness, and low back pain. So next is pain. Fibroid causes dysmenorrhea, which is pain or difficulty in menstruating. Dyspareunia, which is pain during sexual intercourse. Acute severe pain in degeneration or torsion of pedunculated fibroids. So those fibroids attached to the uterus by means of a stalk. When they are degenerating or there is a torsion, they cause acute severe pain. Next is reproductive effects. So fibroids cause infertility, especially submucosal fibroids. There's usually recurrent pregnancy loss, preterm labor, that's labor before 38 weeks, malpresentation, obstructed labor. So when the fibroid is large, it could obstruct the cervix, the the internal cervical opening, resulting into obstructed labor. So next is physical examination findings. Fibroids are usually enlarged, irregular, firm, and causes non-tender uterus. So on physical examination, the uterus is usually enlarged, irregular, firm, and non-tender. That's if you touch it, the patient wouldn't feel pain. They feel lumpy or nodular. They are not smooth. So when you examine by palpation, you feel the stomach, the abdomen, the the fibroids is usually nodular, it's rough. Yeah. So next is diagnostic work up. First line, what you do is pelvic ultrasound. You could do it transvaginally or transabdominally. This determines the size, the number, and location of the fibroids. Others, that's the other diagnostic workup you can do apart from the first line, which is pelvic ultrasound. You can do saline infusion sonography, that's for submucosal fibroids. You can do magnetic resonance imaging for pre-surgical mapping. You can do hysteroscopy for intracavitary fibroids. You can do a complete blood count to evaluate anemia as a result of bleeding or menorrhagia due to the fibroid. Next is treatment pathways. Here we have a structured approach on how to treat fibroids. Treatment depends on symptoms, size, and number. Reproductive plans. Does your patient want to continue giving birth? Age and the fibroid location. So first on our list is general slash supportive measures. Here you give iron supplementation if the patient is anemic to boost red blood cell production. You give non-steroidal anti-inflammatory drugs for pain. You give tranexamic acid during heavy bleeding. Counseling on fertility and treatment options. So next is medical management. First is hormonal options. You give combined oral contraceptives. This reduces bleeding. You give progestins, which regulates periods. You give levonorgestrel, intrauterine device, also known as Mirena, which is best for bleeding control. Next is gonadotropin releasing hormone agonists such as leuprolide. This temporarily shrinks the fibroids in 30 to 60% of cases. Used pre-operatively, so it's used before a surgery, not long term due to bone loss. Next is gonadotropin releasing hormone antagonists such as relugolix and elagolix. So there are actually oral alternatives effective for bleeding reduction. Next is selective progesterone receptor modulators, also known as SPRMS, such as ulipristal acetate, where approved. They shrink fibroids and reduce bleeding. So next is minimally invasive options such as uterine artery embolization (UAE). This cuts off blood supply to the fibroids and shrink the fibroids. Good for women who have complicated childbearing, not ideal for women who plan to give birth in the future, that's future fertility. Next is magnetic resonance imaging guided focus ultrasound. So this is non-invasive thermal destruction of fibroid tissue, suitable for selected women. So next is surgical treatment. First is myomectomy, that's fibroid removal. The word myomectomy is derived from uh, Leiomyoma, which is the removal of fibroids. Best option for women who want fertility. We have different types of myomectomy. First is hysteroscopic for submucosal fibroids, laparoscopic for few moderate sized fibroids, open abdominal for very large or numerous fibroids. Next is hysterectomy, which is the definitive cure for women with completed family size. That's women who have given birth to their satisfaction with severe symptoms, large or multiple fibroids. Women which other treatments have failed. So next is management by age and reproductive plans. Young wants future fertility. So women who are young want to give birth in the future. You give non-steroidal anti-inflammatory drugs slash hormonal therapy. Myomectomy is preferred. Avoid UAE. Symptomatic does not want fertility. You do LNG-IUS. You give gonadotropin releasing hormone agents. You do UAE. Hysterectomy if severe. In perimenopausal women, expectant management is preferred. Short-term gonadotropin releasing hormone agonists. Symptoms often improve after menopause. So what are the red flags? There should be urgent evaluation if rapidly growing fibroids post-menopause. So if fibroids are growing rapidly after menopause, it is a red flag and it should be evaluated urgently. Severe acute pain, that's intorsion or degeneration. Heavy bleeding causing anemia. Suspicion of a leiomyosarcoma, which is rare. A leiomyosarcoma is just the transformation of a leiomyoma, which is a benign tumor, to a leiomyosarcoma, which is a malignant tumor. So in summary, fibroids are estrogen and progesterone deriving benign tumors of the uterus. They cause heavy bleeding, pelvic pressure, pain, infertility, and pregnancy complications. Diagnosis is by ultrasound. Management ranges from medical therapy, such as the use of non-steroidal anti-inflammatory drugs, hormonal agents, gonadotropin releasing hormone analogs, to minimally invasive options such as UAE, and surgery such as myomectomy or hysterectomy, depending on symptoms, size, age, and fertility goals. Thanks for listening, and do not forget to like, comment, share, and subscribe for more videos.